Okay. Okay, so disability and healthcare really kind of should be at the beginning of the chapter, or at the beginning of the class. I mean, it makes a lot more sense because a lot of these things, like how we adjust for somebody who has a mobility issue or a hearing or eyesight or dexterity, how we adjust for it can go across like lots of different groups of people, elderly especially. So I think I'm going to put it back at the first one next year, and then have like diabetes and cardiovascular as the second and third, because it just kind of makes more sense, and it sort of sets you up for being able to apply some of these concepts across the board. So wearing a new hat. So it's not like you're putting on a new hat every time you see somebody with a special need. It can be, I mean, as simple and what doesn't even quite seem like a special need as somebody in braces, like orthodontics, or someone as complex as having an organ transplant or going through cancer therapy, or being paralyzed, from the waist down or something. So treating a patient with developmental disabilities in the dental office doesn't require like a whole new set of skills. You just have to adapt the skills you have to their individual need. So in treatment consideration, we want to think about modifications to the typical care plan. That's the essence of having a special needs requirement in clinic, is just thinking, what person did I have to do something different? And the easiest one is the blood glucose. Like, we take blood glucose on anybody who's pre-diabetic or diabetic. And that's something different. Like, you wouldn't do that on somebody that doesn't have any systemic conditions at all. So it's sort of built into your type of practice, because we see patients with a higher rate of these conditions. But not without that, you still want to consider, what other kind of accommodations? Did I not use as much water because they have difficulty swallowing? Did I not set them back as long? Or did they have trouble keeping their mouth open because of something, going on? Did they have whatever it is? You just always think about how you might have to adjust your typical care. So a special need could be transient or just temporary. It could be something, a broken arm that someone's going to heal, or broken leg. Or it could be a chronic condition that lasts their lifetime, or some kind of a condition that they were born with or that happened from trauma or something. Physical, mental, or developmental. So it can be any of these categories. And this is just that law that was enacted in 1990. The ADA is a civil rights law that prohibits discrimination against individuals with disabilities. So it tries to sort of even the playing field so that they can participate in society just as anybody else. So sometimes it's something as small as widening a door so that they can get in if they're in a wheelchair, or handrails to help support, or something, certain codes for the building, just so that they can get in and out of the building just like anybody else, and that their disability doesn't prevent them from functioning in society. Defining disability: a person who has a physical or mental impairment that substantially limits one or more life activities. So sometimes it's visible and sometimes it's not. A lot of times, if something is not visible and then you start to notice something afterwards, you might be like, what's wrong? What's going on with this person? Especially if they haven't disclosed it, or you haven't been able to read a medical history and they haven't disclosed it. And other times it might be apparent, like something physical, or, something that you can pick up on easier. But a major life activity, those that the average person can perform with little or no activity. So you can just think of all the things that we do during the day that don't take a lot of effort or thought. We just do them. Those things might not come as easy to somebody with a disability. Diverse spectrum of individuals with different needs, can be small, can be large. And then the interprofessional opportunity, there's more to it, but I just snuck it in here because I wanted to make sure and say that, when it comes to accommodations for people that have special needs, occupational therapists are wonderful resources. They deal with a lot of the thought process of how somebody functions in life. And that can be something as small as brushing their teeth. So occupational therapists, they sometimes think about these things like, well, how do we get you to cook your meals? How do we get you to brush your teeth? How do you, so they're a wonderful group to sort of powwow with whenever if you have a patient that you think is maybe seeing an occupational therapist or could benefit from, or you just reach out and talk to one about some of the overlapping areas where you both might have the same interest or thought process or learn from each other. So when they talk about disabilities, there's sort of this spectrum of conditions. So it can be something like self-care, walking, hearing, seeing, breathing, standing, like some kind of big things, speaking, sitting, learning, thinking. So sometimes learning and thinking falls under the, it's not as obvious at first, maybe, interacting with others, and then immune system and normal cell growth. So that might not be something that somebody sees at all. And then major organ function. So you can see it can be something really sort of what you might think of off the top of your head as a disability, and something that it could be completely not seen at all. So when interacting with people with disabilities, patients with special healthcare needs, there's a broad spectrum of individuals. So dental hygienists, we kind of have to just apply critical thinking. We have to think about this in terms of their informed consent as well. Like, are they able to give consent? And oftentimes, yes. And then, but sometimes no. So you kind of have to like think critically about what's going on, what they can approve or not approve, who's with them. And they might have somebody with them to help them physically, but they're not at all in charge of their cognitive decision process. So it just sometimes, it's just going to vary widely. So you just have to be ready to sort of think critically, maybe ask a few questions. Shouldn't assume a personal characteristics about how a disability affects somebody. I had a patient at Dr. Matsuda's who I think he had muscular dystrophy, and quite unstable, but still able to come in. Lot of shaking, and like some difficulty with dexterity, but man, was he ever independent and high cognitive function, and like way smarter than me. Like he would talk about books he was reading and all this kind of stuff. And not that his condition doesn't make him smart, but sometimes when people see someone that really struggles physically, the first thing they might think is maybe they suffer in other areas. And so it's a really important thing to not kind of categorize someone as sick or not happy, even. Like someone might be totally happy, so just all of these sort of assumptions. If somebody is in a wheelchair or if somebody seems disabled, a lot of times you can pose the question like, how can I help you? Or can I help you? And even if it's very clear that they probably could use help, simply giving somebody like that dignity of asking them first can oftentimes just make all the difference, especially establishing rapport and helping them to feel kind of good about themselves in the situation. So we like to talk about this person first language, and I mentioned that at the beginning of the semester, and it can still be hard. I mean, we can still sort of slip up when we talk about our patients with different conditions, and it's not the end of the world, but in general, you always want to think about the person before their condition. So you just don't want to label them based on their condition. So this is my patient or my client, Mr. Edwards. He has MS. This is my MS patient, or something like that, or this is my diabetic patient, or I have this one diabetic patient, so you're sort of thinking about their condition, and you may be specifically highlighting their condition in a conversation. And of course, that's different, especially if it's sort of a professional consultation, private kind of conversation. But you obviously don't want to think of it in terms of, she's my paralyzed patient, my disabled patient, etc. And of course, the term handicapped is not really ever used. It's not really considered acceptable. It seems like more of a negative stigmatism, and it implies the person is disadvantaged, which is in general, they've tried to make great strides to make people be able to function at a similar, if not the same level, depending on whatever disability they may have. So for dimensions of disability, there's three primary dimensions. There's impairments, which are like a loss of a limb or possibly a body organ. a broken limb. So obviously you can have an impairment that gets better. If you have a broken limb that's severely broken and maybe it doesn't function quite to the same extent that it did before it was broken, that could still be considered, you know, like maybe a mild impairment, but it might not affect your quality of life very much at all. Then there's activity limitations, difficulty in performing basic activities of daily living. You can think of basic activities of daily living as being able to just sort of feed yourself and shower and get up and get dressed. And then there's participation restrictions, inability to engage in everyday life activities for reasons that may not be under the patient's control. So if you're a working age adult and you just can't quite get into the working environment because of a severe health condition. So that would be, you're just restricted to participate like most working adult aged people because of something that you have. So we want to also kind of consider functional status.
Sorry.
Yeah.
Going back to the last slide, do they kind of like each other?
They can. Yeah, you can probably easily have more than one.
Okay.
Yeah, they can sort of overlap, I think, for sure. And then when we think about functional status, we kind of talked about this also a little bit with our elderly population. So somebody can be a chronological age, and we can sort of base some of their functions on their chronological age, but then there's also their functional age, which kind of says, you know, like they can be very high functioning, even better than somebody that's younger than them, even if they're 98 years old. Like they can be 98 and very high functioning, so they have a different functioning age than somebody that's just chronologically considered old. So these functional status, you can still think about it this in a similar category. It describes how well the patient can conduct basic and instrumental activities of daily living. So you see this ADL, activities of daily living, a lot when you'll see studies about people in nursing homes or people with special needs. And a lot of times they'll refer to activities of daily living. So kind of like it's a metric of how high their quality of life might be, depending on how well they can do these activities of daily living. So your basic activities of daily living: personal care, feeding, dressing, bathing, going to the bathroom independently. And then there's instrumental activities of daily living, which are more complex tasks. And they would be for somebody who can live independently. So using the telephone, preparing a meal, you know, they may be able to get themselves out of bed and dressed, but preparing a meal might just be a little bit farther or more complicated for them to cut up vegetables and get the stove hot and stand at the stove and cook, or, you know, whatever it is. Of course, now we have microwaves and that's easier, but, you know, you can see how, or cleaning the house or driving themselves somewhere. So it's sort of like, we think of those basic, like getting out of bed and showering is really your basic, but then there's sort of these extra things that we do, like just driving ourselves around. And those are instrumental activities of daily living. So some common misconceptions: individuals with a disability are sick. They may not be sick. They may have a chronic condition, but they may be like technically systemically healthy. You know, they just may have something like weak muscles or tremoring. It might not necessarily be affecting like their cardiovascular system or their blood pressure or their ability to breathe or their immune system. So they're not necessarily sick, and especially somebody, you know, who has like a physical ailment, like if their hearing is impaired or they're blind. However, there are some really interesting studies about people who have hearing loss have a much higher rate of dementia. And I don't know exactly what that correlation is, but there's a lot of studies out there that have correlated those two. And then dependent on others. So they're not necessarily dependent on others. They may very well take care of themselves fully. It just might take them longer, or they need some certain setup in their apartment or something like that, or in their house. Mentally and physically debilitated, not necessarily again, and then live in an institution or unable to live alone. That's not necessarily true either. So those are just some common misconceptions. Stages of exposure to disability. So there's basically 4, and we'll highlight each one just a little bit more here, but congenital disability, an irregularity present at birth, which may or may not be traceable to a genetic factor. So a lot of times this is something we think of more like as a birth defect, like something that happened at birth. And then there's acquired disability, which would happen after birth. And this can be specifically traced back to a disease or an accident. So something like an automobile accident or a skiing accident or something like this. And then there's developmental disability, the group of conditions with impairment in physical, learning language, and behavioral areas. So it could be potentially something that happened during in utero, but it could also happen after the child was born, and something like a virus or a lack of a nutrient or some kind of a chemical intervention that affected them somehow. And then age-associated disabilities with people typically over the age of 65. So just a little bit more for each one. For the congenital disability, a congenital disorder is a condition that's present from birth. And then these are all some examples of congenital disabilities with a little bit more of a explanation for each. So cleft lip, cleft palate, congenital heart disease, cerebral palsy, Fragile X syndrome, Down syndrome, spina bifida, and cystic fibrosis. And then developmental begin during development period of the child from birth to 22. So it's kind of in this specific age range, birth to 22, may affect their day-to-day functioning and can last indefinitely, can be either mental, physical, or a combination of impairments. And this one is a little bit different. You can see it includes things like ADHD, autism spectrum disorder, hearing loss, or epilepsy. So there's different, and there's others, but those are some pretty good examples. And then the American Academy of Pediatrics recommends developmental and behavioral screening for all children during regular well visits. So they usually screen for any kind of developmental, signs of developmental disability at 9 months, 18 months, and then 30 months. And then in addition, the AAP recommends that all children be screened specifically for autism spectrum disorder during their 18-month and 24-month child checkups. Then acquired disability is kind of easy to remember. So it occurs after birth, and it can be traced back, like I said, to a specific disease or trauma or injury. So you can think of that as like a spinal cord injury that happened from an accident, or it could be like a significant virus or something that permanently left them permanently disabled. And then age-associated, that's just going to be age-associated conditions that tend to happen after, predominantly after 65. So higher rates of cancers, diabetes, cardiovascular disease, not autism, Alzheimer's disease, dementia, things like that. So then we kind of want to think about, and this is a very condensed, this could be like a whole entire PowerPoint, the barriers to healthcare for individuals, because not only are you trying to kind of put all of these barriers into one category, but people with different disabilities will face different challenges and barriers. So you could talk on each sort of area for a long time, but just to sort of, and I put quite a few bits from the text in the notes that you can read through, but this is just sort of a summary of these different. So financial is a huge barrier. You can imagine that anybody with, some more than others. So if it's, something that's self-limiting, like a broken arm, sure, they'll have a high medical bill, but eventually that'll pass and it's not going to be forever. But you can see how some people that have multiple systemic conditions that go along with the disability, or just have to be on medication or treatments lifelong, it can add up. So a lack of funds for their daily expenses, insurance coverage may not cover everything, and very oftentimes dental drops to the bottom of anybody's priority list. Not only is it not always covered, but they just don't have the extra money for it. Out-of-pocket healthcare expenses can be huge, and so not only do they struggle to pay just maybe regular bills for gas and food and housing and entertainment, but then they might struggle to pay their medical bills can be very high. So financial burdens can be quite large. Architectural, obviously that tries to fall under the ADA Act, the 1990 ADA Act, where they tried to sort of address that in all new buildings and retrofit it in older buildings. And sort of when you go to create a space, you're supposed to have all these considerations, but there's still going to be, I mean, patients that I had that were in wheelchairs, it was still a struggle to get them into Dr. Matsuda's room. My office and Scappoose at Dr. Leidy's office, those were much larger kind of openings, and so it was a little bit easier, but my room just happened to be larger than everyone else's, just per chance. It's just the way they designed the building. So it can still be a barrier. And then to be able to move around, get in and out of facilities. Transportation can be big, especially if they are in a wheelchair or something and they have to be obviously picked up by a special vehicle that can help transport either their Jazzy or their wheelchair or their electric. Sometimes they have like electric wheelchairs. So they have to be able to accommodate that. Public transportation can be difficult to navigate. It adds time. I mean, you're adding probably easily an hour to your commute. If you're, even just 20 minutes away, you have to wait for the bus and then they have to come and get you. And, they might drop other people off. I mean, anyone who takes public transportation knows it takes longer. And then there's an expense to that as well. So that's an added expense. And then attitudes is kind of an interesting topic. There's a lot on this. And attitudes can go both ways. It can be the healthcare professionals not wanting to take people with special needs because of a lack of funding. If they're only covered by some kind of state or federal funding, the payout is going to be much lower. Not only that, is there could be many systemic issues that complicate their treatment in the office. They could have, like some kind of, they could have like some kind of tubing or extra thing, like a colostrum bag. Is that what I'm trying to think of? Or they could have, oxygen, or they could have, there could be all kinds of things that complicate their treatment in office. And that could make a dentist or an office kind of hesitate to want to see them, especially if they have to be sedated, if they can't get in and out of their wheelchair easily. All of these things can kind of complicate it. So there can be sort of this unwillingness and kind of hoping that they'll go somewhere else. And then, and it can take extra time, and time is money. So nobody ever likes to go longer than an hour for a procedure. So if they're coming in for a teeth cleaning and they need an hour and a half, they aren't going to love that. And then there's the attitudes of the individual with the special needs, feeling misunderstood, feeling embarrassed, feeling insecure, feeling that they don't understand all this stuff and they don't want to ask about it. So they might feel like there's a barrier just because people don't understand or people don't want to help them or take the time, or that they're misunderstood, their condition is misunderstood. So there's all sorts of barriers to consider, and a lot of times individuals with severe disabilities or special needs oftentimes have a lot more oral health issues because of their lack of ability to sort of integrate into the system like a typical person. Okay, so now we'll talk a little bit about some of the assistive devices. So that's sort of a background that sort of encapsulates like anybody and anyone with some kind of a special need or, minor to a major disability. You kind of think about that when you're thinking of all people that you'll care for in clinic, but now some specific things that you might see. So if somebody has difficulty with mobility or ambulation or walking around, they might have one of these little sit, scoot kind of things. My grandma used one of these for years. So they might come into your office with that. And so they use it a lot of times to they hang on to it as they sit down in your dental chair. So you want to let them use it to their comfort level. And then you tuck it away and you kind of let them know where you put it and you keep it close by, because that's a lot of times sort of their security. They like to know where that is and they like to use it to get in and out. Same with a cane. There could be leg braces or crutches. And so you want to keep those devices close, retrieve them when the patient needs it. And if you move it, let the patient know what you're doing with their assistive device if you have to move it. We'll talk more about wheelchairs, but someone who's in a wheelchair may be able to transfer themselves, and it might be a little obvious if they can or if they can't, but either way, you still kind of want to ask them, can I help you, or how can I help you? If they may not even want help, they might be able to slide themselves over. And oftentimes it would just be easier to treat somebody in a wheelchair. It's definitely not ideal. They do have different adaptive things. They have devices where a wheelchair can roll up onto a little kind of platform and lock in, and then the platform tilts back. That's amazing, because the best thing to do would be if the patient could just stay in their wheelchair. And so if you can get them to tilt back, or if you have an extra kind of adaptive headrest that you can attach to the wheelchair, and then they can rest their head back, because people just can't hang their head back like this. I mean, that's just really uncomfortable. And so then that means you're like this. And that's really uncomfortable. And that happens a lot in nursing homes, or if you're seeing somebody in a wheelchair. It's really uncomfortable for all parties involved. So it's not ideal. And we'll talk a little bit more about wheelchair transfer. But that is something you would never, ever, ever want to do on your own. There are one-person wheelchair transfers, but never transfer somebody by yourself. If they're small framed and you're strong, just have someone watch to make sure that it goes okay. But like, I've never felt physically strong enough to like pick up a human being and move them over. It never would have been something that my body would have wanted to do. And so I just know that. And so it's always far safer to do it like a 2-person or a 3-person transfer. Okay, and then prosthetic devices. So somebody may have prosthetic limb, prosthetic leg or arms. And then for joint replacement, I just posted in what's in the clinic manual. We don't pre-medicate, just across the board. We don't just automatically pre-medicate for joints anymore, but we do honor if the surgeon wants them to be pre-medicated. So you can ask them about it. Like if they mark joint replacement, you could say, does your surgeon want you to be pre-medicated? And if they're like, I don't know what you're talking about, then you can be like, okay, I guess not. Or if they say yes, then you say, well, did you take it? So you can follow up like that. But in general, we are not saying you need to be pre-medicated. Hearing aids, somebody may have a conventional hearing aid, they may have a cochlear implant or a bone anchored hearing aid. So there's different types. And just the one thing to know is they may need to turn it down, especially if you use an ultrasonic. It can be very squealy. So they may actually want to turn down their hearing aid. If a patient is unresponsive to questions in conversation, maybe they need a hearing aid, or maybe they forgot their hearing aid or forgot to turn it on. There you go. So sometimes you have to, it's a good way to kind of, some people smile and nod, but they actually didn't hear anything you said, and they just kind of are used to pretending like they hear people. And that can be a problem if you're trying to talk to them about your treatment or oral hygiene care or anything like that. So sometimes you kind of have to be a detective and pick up on those clues. For vision, you may need to have like a magnifier, you may need to have large print, handouts, contrasting colors, things. If somebody left their glasses at home, then make sure you give them something that they can take home and look at, or someone can read to them later. Treating patient with complete blindness, there's a certain way that you kind of just offer your elbow. You don't ever want to like lead somebody, like kind of like push them around. They have an instinct of where they need to go. And so it's more of like a passive thing. And so you offer them your elbow, and then they will just sort of feel your body and how you're moving. And it's very instinctual for them. So you don't want to make it more complicated than it actually has to be. And then just provide simple instructions, like you'll take 3 steps and then the chair is on your left. So something like that, so just to give them sort of a mental idea of what the room might look like, a picture. And then guide dogs are permitted in treatment area rooms. And some people have therapy dogs too. Some dentists have therapy dogs, which I just think that's so much fun. So other assistive devices, there's speaking devices that kind of mimic sound, pictures, symbols, drawings. There's things called mouth sticks. And if somebody is paralyzed from the neck down or have very limited use of their arms, they may use a mouth stick that has various attachments. So it basically looks like a mouth guard with just various, it might just have a stick for pushing on a computer, like a keyboard, or I've seen one with like a paintbrush if they paint with it or something like that. So there can be different kinds of attachments to it. But if they do have one, and if you have, I never saw one in clinical practice. I never actually knew about it before I started learning from this class. But if you happen to have a patient with that, you would just treat that like any other prosthesis. It's like, do you clean it? How do you clean it? Is it fitting in your mouth okay? Is it causing any kind of trauma to your teeth or TMJ? You know, so you kind of just consider those same things that you would consider with any other oral prosthetic that somebody has or a prosthesis. So in terms of cognition, you want to think about different ways of communicating with people or different ways of educating. So you may provide a task list. You may have picture schedule or like a picture of like, first you're going to do this and then you're going to do this, you know, to give them like a visual, or a calendar of event, you know, this, you'll do this in the morning or this in the evening, or however it needs to be. Picture-based instructions. We don't really understand the level of people who may actually be illiterate or not be able to read. And that's not something that people just sort of come out and go, oh, by the way. So it would be hard, and there's still kind of talk about this and how to figure this out, how to find out people's reading comprehension level, especially if it's an adult. But it's not a bad idea to add pictures to things for instructions, for especially kind of basic instructions like oral health care and education in that term. So that could be helpful for many different areas, but especially for if there's some kind of a cognitive disability, obviously. Timers, manual or automatic reminders, smartphone. This is great for elderly people who are starting to forget stuff. Put a note on your mirror, like, did you brush your teeth this morning? And just keep it there. And then when they come into the bathroom, they're like, oh, did I brush my teeth this morning? They may end up brushing their teeth like 5 times, but at least their teeth would be clean. And it would remind them to do it. And then also they can set a timer on their smartphone. Schedules and calendars, audio recordings, that they can listen back and remind them of what the instructions were. So these are some assistive devices for other kinds of disabilities that you might not think about, like this is the obturator. We've talked about these before. These can be used on people who've had oral cancer, remember, or someone who has a cleft lip or a cleft palate rather. And so after surgery or before surgery, to kind of plug up that space in the roof of the mouth, the palate, into the sinus areas. So something like this might be what it looks like, and then the obturator kind of closes up that area. Some people with cognitive disabilities, severe cognitive, might do self-injurious behavior. They might bite or bang their heads or do something that harms themselves on a like habitual repetitive basis. So if they have a habit of biting their lip, they can get a huge, like this is just a massive callus, like a huge callus from just like repeatedly like sucking and biting on their lip. And so then there's would be like a mouth guard or something to try and prevent them from being able to do that so much. Other things that we want to think of, and this is great for when we're thinking of anybody with a dexterity issue or limited range of motion, elderly people or younger people with various disabilities. We want to think about how we can adapt their home care tools. Range of motion, grip strength, skill level, and cognitive application are all the 4 main things you'd want to think about when thinking about how you might have to adapt something for them if they need it. You want to make sure that when you talk to them about adapting a toothbrush in a certain way or some other device, that it's lightweight, easy to use, maybe even have them bring it to the appointment so you could see how it would work and how, if they could actually really use it. Is it readily available, easily accessible things like putting a tennis ball in at the end of your toothbrush is pretty easy, or foam or something, but is it water resistant? Maybe not so much. So maybe something rubber would be better, or something plastic or rubber would be better. So you just, you just kind of can, there's lots of ideas out there. Inexpensive, easily constructed, interchangeable, so that if it gets yucky, they can just throw it away and use something different. There's just tons of different ideas out there. You want to think about their skill level, ability to follow directions, ability to read and comprehend, the perception of things being easy or difficult, kind of get an understanding if this process that you're coming up with is easy and they think it's easy, or if they're sort of lost in all the things that you're trying to tell them. So you kind of have to just get an assessment of your patient's cognitive ability in that way, or their skill levels. What's their current oral status, and their current, like, how are they currently taking care of their mouth? What's their routine? What's their range of opening? And then what's happening with their oral musculature? Do they have a strong cheeks that are pushing something, or is their tongue thrusting or doing something that's affecting their oral care, or even the shape of their mouth even, or just how, sometimes if their tongue is very strong, they may be pushing their toothbrush from the back. And so they never actually access the back of their teeth because their tongue is like constantly like blocking and pushing. And that can be somebody who's not even cognitively impaired. That can just be someone with a strong tongue. But if they have a very strong tongue thrust, that could make it even stronger or even harder. What's their strength and what's their dexterity that goes along with grip strength and range of motion and all that. They have all kinds of neat things. They have these little devices that squeeze out the toothpaste. And so they just stick their toothbrush in there and it dollops a little bit of toothpaste. They have toothbrushes that have multiple sides so that if their dexterity is poor, they don't have to rotate their wrist. They just kind of get in there and just go back and forth, and it kind of encapsulates the tooth. They have all different, and they're, these, like maybe a strap to hold if they can't grip at all, just to get the toothbrush kind of strapped onto the hand so it stabilizes a little bit. All kinds of stuff out there. So these are just some ideas for constructing an oral device, so you guys can read through that. I highlight the occupational therapist again. They may have wonderful recommendations. So now we'll shift gears a little bit and talk about stabilizing a patient. So when we think of who might need to be stabilized, it could be somebody with severe behavioral issues, severe anxiety, not able to just adapt to a situation where they would lie calmly, but it would, provoke some kind of hysteria or extreme anxiety, and they'd be flailing and not be able to handle it. On top of that, it could be somebody that involuntarily can't control the movement of their head, or like their arm would just like be moving the whole time, and that would be very dangerous. So it could be somebody who's cognitively calm, but their body isn't cooperating. So patients with disabilities frequently have problems with support and balance. So it could be something, as simple as just needing special support. Protective stabilization is an advanced practice, and it's subject to increased regulations. You can't just tie somebody down and be like, this is for your best good, so I can brush your teeth. It's pretty specific. You have to get informed consent. You have to document why you're doing it, and how you're doing it, and that the patient is okay with it, or their caregivers. Didactic and hands-on education is needed, requires informed consent. Dental hygienists must explain indications, benefits, associated risks. So these two terms you need to know: active stabilization, and these can be a little counterintuitive. Active stabilization involves physical immobilization by another person. So this could be something as sort of benign as like a dental assistant sort of holding down the hands of an active child. That's active stabilization. They're actively kind of holding them down. Passive stabilization is if they're in something that is like a device that's holding down their arms, or there's papoose boards that like wrap them up or or put a band across their head to keep their head from moving. So that's passive if it's like a device. Another thing that's passive could be like a bite block or a mouth prop to open up somebody's mouth. That's a passive device. And so active is more like a physical hands-on. Patients with neuromuscular impairments may require stabilization. Patients with aggressive behavior, mouth props are helpful. You want it, and this is good for you guys to know just in clinic in general. If anybody needs a bite block, make sure that you've thought about if they have any teeth that are mobile. You don't want to put a bite block in on any teeth that have mobility. And I mean, like, you know, fairly significant mobility. Like, you know, if it's like class 1 mobility, it's probably fine to use a bite block. But if it's like really mobile, you don't want to use a bite block because you don't want to risk that their jaw doing something funky and like the tooth, especially if it's really mobile and they have a lot of unanticipated movement. You can see how this would be more severe in certain situations than others, but you wouldn't want the tooth to come out or be avulsed and then have them swallow it or inhale it would be the worst thing. So you have to kind of think about that when you're thinking about a mouth prop or a bite block. So patient positioning and stabilization, it could be something as simple as pillow behind the neck or the knees or the lower back. That's pretty benign. We do that a lot. Belts or straps holding patient's head or hands steady. A beanbag chair, a mouth prop, patient positioning semi-reclined. And then you can see these large kind of papoose boards or like larger restrictions here. This is another common thing that pediatric or general practice do with kids that are usually like under 3. Mom holds the body and then the head goes in the dentist's lap so that they can look at the kid's teeth that way, and they still feel the security of mom or dad holding them or whoever brought them. And that's a pretty common, and that would be a form of like active stabilization, and the parent is the one that's kind of holding the child. These are other examples. You can see there here the assistant is holding the arms, and this these are like little sleeves that hold the arms down. This is an article, I think, that you can look at on your own that has some, I looked at it last night. Now I can't remember what it was. Oh, well, you can click on it and see what it was. It might just be an article that might just have some of the guidelines. I think it goes into detail about what you have to consider if you're actually going to use something like belts or straps or a papoose board. And then advanced behavior guideline. This talks about the 3 main sort of categories, which is protective stabilization, sedation, so drugs to sedate the patient, or general anesthesia. Some patients simply have to go under full-on general anesthesia. It's very sad to see little 2-year-olds or 3-year-olds going under general anesthesia and they have rampant decay. It's an incredibly sad situation. That was a rotation I had in hygiene school where we went to a hospital and they just brought in this little limp like toddler and they just had rampant decay. And they fixed it all, and it has to happen, you know, they can't just leave it like that, but it's not the healthiest thing to go under general anesthesia, right? I mean, it actually like cognitively can leave a little bit of a mark, even though children are incredibly resilient and they usually are just fine on the other end. And people have to go under general anesthesia for all sorts of reasons, but it's not something like you want to have happen, right? But this is sometimes what has to happen with little ones, or somebody with severe disability might have to go under general anesthesia or heavily sedate them. So many patients with disabilities, I feel like we already kind of said this. You may need to use a rubber dam or like an isolite. Is that what it's called? Isolite. Dental hygienists should limit the use of water or other fluids if the patient seems like they'll have difficulty swallowing. That you can think of with other types of conditions as well, not just somebody with like a cognitive issue, but also just some systemic conditions. And then, so here we talk a little bit more about the wheelchair. So here are these platforms that tilt back. These are wonderful. If an office, you know, it wouldn't get used a ton, and therefore many offices don't actually invest in having these, but larger corporate offices should probably think about having a room where this is available, you know, because they're going to see a much larger group of people and they oftentimes maybe have a bigger budget. It's harder for smaller private practice to dedicate a whole space with this. So you won't see it very often out there when you go out, but maybe public health or some, you know, some different kind of entities might actually have, certainly nursing homes could have these, and they make it a lot easier to see a patient. The dental hygienist should not attempt to transfer a patient alone. Although one person transfer technique requires only one person, you should have a second person there to kind of supervise. One person should not attempt to transfer a patient who's very tall or heavy, especially a patient who has minimal upper body strength. If they're relying on you like totally, you just have to be extra careful. You don't want to throw out your back. I mean, your body is already going to take a little bit of a beating because you're a hygienist. So you just really need to protect your body. I had a patient one time, and it was not long before I stopped working clinically altogether. But I went out and he was a larger, older man. And, you know, sometimes older people have a hard time getting up out of the chairs, you know? And so he's like, come here and help me. And I was like, okay. And so I went over there and I gave him my arm. I'm telling you, he almost ripped my arm out of my shoulder socket. It hurt so bad. And I'm like wincing and pretending like everything's okay. And he was so sweet, but it's like, no, I shouldn't have done that. I mean, and he like really tried to use me to help pull him up. And I mean, he was much taller than I was. So just, you know, think situations through before you get your arm ripped out of your socket. Okay, dental hygienists should perform transfers with feet separated, good balance, never pull and twist. You know, you're supposed to like do the like bend your knees and lift. They should have some kind of supportive belts. We'll see, there's some videos that you'll watch. And there's a good, at the end here, I added a Quizlet that has an excellent sort of summary of like the things you kind of need to know. But I still say never, ever do it alone. Always go to your dentist and say this person, you know, find out if you do have somebody that comes in a wheelchair, find out what the office protocol is. Don't have it be like, oh, that's your patient. Good luck with that. Like you need support to not feel like you have to figure out how to get the patient out of the chair into your dental chair. There should sort of be an office protocol. And so that's something that you can talk about beforehand. Some things to note specifically, people who are in wheelchairs due to some kind of paralysis, they may have an assistive bowel or bladder device, catheters, or a collection bag. And this is very important. If you move them and something gets twisted or pulled free or something, not only can it be dangerous for the patient, but it could be messy. And so you have to make sure that when they're moved, everything is situated sort of back, core, or like tubing is all the way it should be, and that the bag is in an area that is appropriate for the patient's needs. So you have to think about that. A damaged catheter can result in inadequate bladder drainage, toxic waste accumulation, could trigger an emergency. So that could be quite serious. A consultation with the patient's physician about specific medical concerns is recommended. Muscular paroxysm, so muscle spasms could also be triggered if you move somebody out of the wheelchair, and that could be very uncomfortable for the patient as well. They're at risk for experiencing muscle spasms. Pressure injury patients who sit a lot can have areas that they can have damage and bruising to the underlying tissue, especially if it's something that always has pressure. And so they could be more susceptible to injury. So if you move them in a way that's sort of not careful or causes some kind of abrasion or extra injury, if they kind of knock them into an armrest or something, I don't know, I'm trying to think of how it might happen. It could cause ulceration or open up a wound. And so they might need extra padding, and you have to think about that as you transfer them out of the wheelchair into the dental chair. Okay, guidelines for preparing wheelchair transfer. Preparing the wheelchair, you want to remove the dental chair armrest, relocate equipment such as hoses, foot controls, operatory lights, clear it all out, open it up, position the wheelchair near the dental chair, the patient's level of coordination and balance can assist in determining their needs. Sometimes they can push themselves up and slide themselves over, and boy, that would be great. Transferring from wheelchair to dental chair, the dental hygienist should also check nearby areas for sharp edges, hazards, obstacles. The hygienist should transfer any special padding underneath the patient with the wheelchair. Transferring techniques require practice, and sort of that's why I think it should be kind of talked about in your office, Katie.
One of the things is great. Those chairs need to be on.
Oh, very good.
Down because they're a little they push out from behind.
Yes.
They back down and out and you're stuck.
Yep.
So my seat be on, and then I know what the friends call me. So once you kind of like swing into it.
Yeah.
1, 2, 3.
And then up.
So sometimes
Yeah.
something like that kind of helps.
Yes. Little momentum, and then they're ready for it too.
Yeah,
And
it kind of just,
yeah.
yeah.
Good. Yeah, that's great. Yes, breaks for sure. That should be in the PowerPoint. Dental chair, I'll have to add that. Dental chair should be slightly, so if you're going from the wheelchair, think about just the path of least resistance. If you're going from the wheelchair to the dental chair should be slightly lower, right? Because you don't want to like hike them up and over. And that can be a problem if your dental chair just simply doesn't go that low. That can be a problem. But then when they go from the dental chair back to the wheelchair, again, path of least resistance, you don't want to put them up into the wheelchair, just hopefully they'll slide kind of down into the wheelchair. So the dental chair should then be slightly higher. So whatever they're moving from to should be lower. Whatever they're moving to should be lower. Slightly lower. Okay, so there's no time for me to play these, so please watch these on your own. This is a one-person transfer. It's very short. It's too short, really. It doesn't show it very super great. This is two-person, shows it a little bit better. And then this is a quadriplegic transferring herself into a dental office. This lady has a bunch of great videos. She is, I mean, she's had like babies, and she's talked about how she cares for her babies in, you know, being paralyzed. And I mean, she just has the most positive, amazing outlook on life. I just really enjoy watching her videos. So this is her transferring herself. So do watch that. And then this is a Quizlet to click into, and it summarizes one person and two person and some really good points. So instead of just adding more slides, I just want you to kind of go, there's like 15, it's like a Quizlet of like 12 or 15. So just really look over those, and that's pertinent information that you want to know. So that's all for this one. We still have another PowerPoint, but it's shorter. So I'm going to give you guys 10:20. We go till 10:50. So we have 30 minutes. Okay, so take 10 minutes, and then I'll see how much I can get done in 20 minutes. So come back at 10:28. Okay, you guys, I am going to fly through this so that I can get it out. Hopefully I can get, there's only 28 slides. Hopefully I can get through this. And then there's still a few people that haven't grabbed this. You can grab, don't forget to grab one on your way out. We only had the one, yes, just the one. So intellectual and developmental disabilities. There's the objectives. So developmental disabilities, we kind of talked a little bit about, well, this is sort of a little review. Lifelong, severe chronic disabilities that can be cognitive, physical, or both. And really, I think, I don't know about the severe always. I don't know if that's true, because I feel like we said the opposite in the last one. IDs, so they're oftentimes they're sort of summarized as IDDs, intellectual and developmental disabilities. They kind of lump them together. Intellectual disabilities, developmental disabilities are characterized by significantly sub-average general intellectual functioning accompanied by significant limitations in adaptive functioning in at least 2 skill set areas, which include communication, self-care, home living, social or interpersonal skills, use of community resources, self-direction, functional academic skills, work, leisure, health, safety. So at least 2 of those, oh my gosh, I'm gonna trip myself. So at least 2 of those skill areas, if they're significantly limited in 2 of those, then that's considered an ID or an intellectual disability. Etiology, intellectual disabilities can stem from genetic or biological factors, chromosomal or genetic disturbances, non-genetic biological and nutritional factors, lack of the proper prenatal nutrition or the proper things, perinatal or prenatal, and also postnatal. Psychosocial factions, inadequate caregiving. Oh, there are studies about babies who are never been, babies in orphanages that are never touched, physically touched, let alone snuggled and held, but just like minimal physical touching, and it can have they're the saddest things to read about, but they can have significant leave a intellectual disability, because humans need physical touch. That's part of what we need. It's like the vitamin T, vitamin touch, and it's so important for babies. So there are these levels of intellectual disability, mild, and I just want you to, the what's bolded here, you just have to, you will be tested on these, so just kind of pay attention to some of these bolded words. So if someone has so normal IQ is 90 to 110. Usually once you get to mild ID, you're like 75 or less. You're like into the 75 IQ range, but they're still educatable. There's perfectly able to teach oral hygiene and things like that, able to learn, but attention spans and memories are short. So short memories, you got to think about that in coordination with how you're teaching oral hygiene. Moderate ID, poor hand and finger coordination is a big one here to pay attention to. Severe ID, learned by habit training. So it's a different type of teaching. And then profound ID, incapable of self-care. So somebody's going to do this for them. Someone's going to care for them. Yeah. No, you don't have to memorize the IQ range. It's there for kind of nice to know, but you don't have to memorize that. The question might say something about a way of teaching somebody and then have to attribute like what kind of level, mild, moderate, severe. So some different types of reward systems that can be used in some of these scenarios with people with ID. Attention, social rewards include things like attention, smiling, hugs, praise, signs of approval and affection. Activity rewards, so something that someone enjoys, like you get to watch your favorite TV show, or we're going to go watch a movie, or we're going to go play a game, or go to some activity, like fun park or something. And then material rewards, something like maybe food or money or a present or something. Intellectual disability, general characteristics. Some people with intellectual abilities may have these health issues: less physical stamina, delayed physical development and speech. If there's a mental or a motor ability could be affected, I said that wrong, but mental or motor abilities can be affected. So short memories, unable to concentrate or to see the likeness and the differences between objects, limited speech, lack of adapted, associative, or organizational skills. Social and emotional abilities can be affected, will imitate others, may show behavioral problems to gain attention or to release emotions. Behavior may be destructive, have an awareness of not fitting in, and that can perpetuate some of it, easily discouraged. Criticism is not taken positively, unable to learn social and coping skills through experience. So a lot of times we, obviously can pick up some cues on how to handle a situation better through experience, but that is not going to be simple or even maybe possible for someone with intellectual disabilities. And then self-injurious behavior, we saw this with the self-biting, self-striking, bruxism, heavy bruxism and that can also be a side effect of some medications. So some oral manifestations that could be present: self-biting, bruxism, thick flaccid lips. You can think about that in some people that have severe intellectual disabilities, where maybe their communication is impaired as well. I'm going to set my timer here. Microdontia, malocclusion, delayed tooth eruption, dental attrition and sensitivity, TMJ disorders, periodontal disease due to lack of probably consistent care, and then heavy oral biofilm accumulation, again, lack of sort of consistent care. Modification of dental treatment instruct at the level of the client's mental age. So you could be caring for someone who's 50 who has the mental age of like a 5-year-old. So you have to adapt to the person that's in front of you. May need extra time and more explanation and a different kind of approach to having them, teach them that brushing and certainly, flossing or other things may be subject to just modifications depending on what you feel is appropriate. Utilize caregiver as needed, build trust and a rapport. If you see, we used to have patients with different, maybe some had Down syndrome, maybe some didn't have Down syndrome, but they had some other intellectual developmental disability or and they would come to, I had one office in Arizona, we saw several, like 5 or 6, and they got to know me. And once they get to know you, things flow better. So building rapport and building trust is a big thing. Sequence and make plans and begin instructions based on sort of a sequence. So to go over Down syndrome a little bit, it's the most common frequently observed chromosomal abnormality. It is a genetic disorder. There's an extra genetic material from chromosome 21. Lifelong intellectual disability, developmental delays. There's obviously no cure or change. Usually causes other health problems like heart conditions and thyroid, and there's different health conditions that accompany it. So increased risk for congenital heart defect, and that should raise a red flag for pre-medication. If it's a congenital heart defect, it might be affecting a valve. Alzheimer's disease, respiratory problems, hearing problems, childhood leukemia, thyroid conditions are all higher risk for individuals with Down syndrome. I'm going to skip this. This is just some nice to know, interesting information. You can look at that. There we go. Medical considerations, pre-medication is a big one. Hypotonia, reduced muscle tone, poor motor function, that will affect OHI. Intellectual and developmental delays, that will affect OHI. Hearing deficits, you may need to make sure, and you would do this anyways, kind of make sure the caregiver hears all your instructions and encouragements and any kind of issues. Eye diseases, neuropathological changes such as Alzheimer's, they may degrade as they get older, even into their 30s, 40s. There may be signs of Alzheimer's. Seizure disorders, then that's the medications are going to affect the gingiva. So thinking about how that can affect gingival enlargement. Emotional problems, if they get upset and they don't want to be there and they're not going to be able to handle those emotions. So figuring out how to come across in a relaxed manner, to have it be pleasant, not to push them if they're not having a good day. Just do as much as you can and help them have a good experience so they'll want to come back. I remember having a patient that they didn't have a good day, and so we just rescheduled for a month. Instead of saying we'll see you in 3 months, let's see you in a month. Maybe they'll have a better experience. And depending on their insurance and their financial abilities, these people could afford it. So they came every 3 months with their family member. Sleep apnea was another one on there that they're higher risk for. Large tongue, but not always a large tongue, sometimes just a small mouth. So the tongue just fills up the space more. Sleep apnea is higher. Tooth morphology, microdontia, maxillary teeth more often affected. Shortened roots. You can just read through some of these. Missing teeth, malocclusion, periodontal disease at a higher rate. They can have immunodeficiencies in general, and that might make them more susceptible to periodontal disease, but it can also just be lack of ability to kind of care. But it could also be sort of genetically more predisposed to periodontal disease. So they are certainly at higher risk for it for probably a number of reasons. And then tooth loss, obviously, because of periodontal disease. These are just going over it again. You can read through this. you can see how things overlap. If they're if they have a small mouth, high vaulted palate, large tongue, mouth breather, things are going to overlap. Sleep apnea, candidiasis, mucositis or glossitis, things get inflamed. When things dry out, things get inflamed. So you can see how these conditions can sort of overlap. So keeping clean, keeping moist, keeping fluoride, treatment. So all of these things will help. Modification of treatment patient usually is content and affectionate. I don't know if anyone's ever treated or come in contact very much with someone with Down syndrome. Sweetest people I've ever met. I never had anyone that was grumpy or grouchy. I had other patients with other intellectual disabilities. They didn't have Down syndrome. They just had something else. I'm not sure what. And some of them, I had one guy that was always grouchy, but we still got through it. But Down syndrome specifically, that just loving, sweet human beings. Assess their intellectual level. Sometimes they're like totally like way more intellectually able to conceive of everything that you're talking about than you may give them credit for. Slow, explain the care, simple terminology, calm demeanor, consider the pre-op medications that they may be on, shorter appointment oftentimes, and frequent recare, like 3 months, every 3 months is good. Due to self-care problems, high risk for periodontal disease, involve the caregiver. And then autism, 1 in 54 children, 2020, 1 in 54 children in the US diagnosed with autism spectrum disorder, higher in boys than in girls. And there's just sort of a wide spectrum. They're just talking about it now. You guys have probably heard this. Just instead of defining it like specifics, like a specific type of autism, it's sort of just a spectrum because it can affect so many people in different ways. Boys 4 times more likely than girls. Most children are still being diagnosed even after the age 4. 31% of children with ASD have an intellectual disability, so intelligence IQ below 70. Autism affects ethnic and socioeconomic groups alike. Minority groups do tend to be diagnosed later and less often just because of sometimes just the lack of access to care in general. And then early intervention affords the best opportunity to support healthy development, deliver benefits across the lifespan. There's no medical detection for autism, so it's just by tests, really. So it's not like they can take a blood test. It's just sort of different types of tests. 40% of people with autism are nonverbal. 28% of 8-year-olds with autism have self-injurious behavior, head banging, arm biting, skin scratching. Other conditions that oftentimes accompany autism spectrum disorder, sleep disorders, anxiety and depression, big one, schizophrenia, GI issues, also seizures and obesity. And then first characteristic signs of ASD, lack of posture when being picked up. So they start to pick up there's some signs when babies are real young, depending on the rigidity and the strength and their postural. There's tests that the doctors are starting to do more now to pick up some kind of clues about it. So this picture sort of shows all of the overlapping things that somebody with autism may encounter. So social deficits, language, and repetitive behavior. And then there's all these other sort of bubbles that can overlap and affect each other. Sleep deficits, mood, anxiety, hyperactivity, attention. And then that can lead to these anxiety disorders, mood disorders, sleep disorders, OCD, ADHD. So you can see they kind of, when they combine, they can have a higher likelihood of having the next bubble. And then immune dysfunction and GI disorders are kind of outliers. So Asperger's, 2013 Asperger's syndrome and other previously separated types of autism, they're just folded into this one umbrella. So this is what this slide talks about. And the latest DSM-5 talks more about the official diagnosis. These are old terms in the yellow box, but you may still hear them. So just for sort of familiarity's sake, I kept that in there. And then just things to think about, social communication challenges, spoken language, gestures, eye contact, facial expression, understanding what you're meaning by your facial expression doesn't always translate well to somebody with autism spectrum disorder. They might not be able to pick up on it. Your tone of voice, your expressions might be taking literally. If you're like I'm like way too expressive with my face, and it might be hard to understand what I'm meaning if I'm joking or something. And then social challenges. So recognizing emotions and intentions in others, recognizing one's own emotions, expressing their emotions, seeking emotional comfort from others, feeling overwhelmed in social situations, taking turns in conversation, that kind of cadence, that social cadence of you talk and I talk, gauging personal space. All of these can be challenges. There's different types of treatment. There's psychotherapy, there's dietary interventions. I've watched a really interesting documentary of this family that took their daughter off of all processed foods. Like, I can't even remember what they took her off of. And it was like night and day. It was crazy. So a lot of these things are like, sometimes they can be controversial, or people are like, no, diets and medications can't affect it. But, you just have to keep an open mind. We don't know everything on this planet. We never know what can affect somebody. Educational intervention, music therapy, speech and language therapy, auditory integration. So these therapies can help if started early. Behavioral therapy, commonly prescribed medications, risperidone and aripiprazole. Those are the only FDA approved medication for autism to treat like irritability, but there are other medications that are oftentimes used off label to just sort of address other issues. But those are the only two FDA approved specifically for autism, risperidone and aripiprazole. I might have been saying that wrong, but okay. Just read through these. These are other communication behavior, but I want to get to this last slide. Take home points, this one, and then the very last one. So you will see patients on the spectrum, and high functioning, just mild something, or a little bit more severe. And if you have somebody who's a little bit more severe and the dental office is a scary place, just to think of these things, think of the new environment, the noises, the lights, the tastes, the smells, the interaction. All of these things can be highly stimulating and make an appointment not go well. So you can think of things like dimming lights, having them bring sunglasses, headphones, music to listen to, and desensitizing appointment where they just simply come in and sit in a chair and you talk. Play dentist at home, especially if we're talking about young kids. Like, bring some stuff, give some stuff to the mom, and give some instruction on how to sort of tell the child how it might turn out. So there's lots of things you can do to sort of prime them for a good experience, and then it's all about taking it slow, letting them touch and feel. If they have taste aversions, don't use toothpaste or prophy paste. Maybe don't use the prophy polisher, just brush their teeth with the toothbrush, and build rapport and trust. And a lot of times you can get people to work with you once they know you and they know the environment. And there's a lot of things, sometimes patients on the spectrum, they really like mechanics and they like things. So sometimes it's like, how does this work? And let me see. And then once you let them like use it or play with it or something, then it's okay. So there's great literature out there. This is just sort of a summary to tips for making the dental visit a success. So just things to consider when you have a patient that you can tell is gonna have a harder time. In general, if parents know that they have kids that are on the spectrum and they start bringing them in really early before you even have to do anything, it might not ever be a problem. If they start coming a little bit later in life, it might be harder. So you just have to take things slow. But just read through this slide for some of these kind of specific and thinking about food and diet. Sometimes they have my last thought, sometimes they have super picky diets and they only want to eat like fermentable carbohydrates. So then you might see a lot of higher caries risk. So then you have to talk to parents about nutritional counseling and how to try and introduce some foods that aren't just for, processed sugary foods. So that's it. Don't forget to grab your paper here. I can't believe we got through it. Yay. I hope I didn't go too fast that you guys didn't, hopefully that sunk in, but you can always re-listen to it.